a great honor today to have you, Dr. Rimawi. Dr. Rimawi is a professor and the executive medical director of the Dan L. Duncan Cancer Center at Baylor College of Medicine. He also has big shoes that he fills, leadership roles at both the TBCRC and the NRG Breast Committee. And if that's not enough, he's also one of the world global experts on HER2 positive breast cancer. And me personally, he's my mentor. He played a huge part in the foundation that I currently have, and he played a huge part in my career. So Dr. Rimawi, thank you so much for being with us today.
Jason, thank you for the kind introduction. I'm happy to be here.
I'm very happy. I'm very happy to be with you here today. And we have a lot of exciting stuff to discuss. ASCO just finished, and a lot of data were presented at ASCO that pertain to breast oncology. Mainly one of the big studies that was presented there is the Destiny Breast 09. Highly anticipated, highly awaited study that finally got the first interim results. Can you talk to us a little bit? I know you played a big role in that study. Can you tell us a little bit about the design of the study and the results that they were presented at this ASCO?
Yes, Jason. So Destiny Breast 09 kind of came as a logical sequence to the studies that were already being either designed or conducted with T-DXd, a very active agent that we saw in the third line and beyond be very active, then with Destiny Breast 03 being very active in the second line setting. So the idea is, can we move T-DXd to the front line setting? And the design of the study was really, the idea behind it is to move it up against, of course, the CLEOPATRA regimen, which was reported by the late Jose Baselga in 2012 in San Antonio, so over 12 years ago, and has been the gold standard. And the study was, that was a control arm. And then there were two experimental arms. One was T-DXd by itself, and the second was T-DXd plus pertuzumab. The idea is that maybe pertuzumab and the dual inhibition, that is with the trastuzumab portion of T-DXd, and pertuzumab are still important for those patients in the frontline setting. And I think it is important because earlier in the course of the disease, signaling by HER2 is probably very important. So I think it was a very good design decision. Now, that was the design. The study enrolled globally around the country, and its leadership had really a group of very talented oncologists across the world. And reported in ASCO by Dr. Sarah Tolini, our colleague from Dana-Farber Cancer Institute. And as you are aware, the study showed that the arm with T-DXd plus pertuzumab did cross the interval or the interim analysis, essentially threshold, which is a very strict threshold, and as such is being reported on compared to THB. So what we know is T-DXd plus pertuzumab really had a progression-free survival that it currently sits at about 41 months.
Yes.
And I say currently because it will continue to evolve with more data.
Yes.
And then the THP arm is at around 27 months with the central review and about 21 months with investigators' assessment. So all in all, a very positive result in terms of improving progression-free survival. Second progression, PFS2 looks good, and overall survival is still early, but in the early stages, and so it's trending in the favorable decision or favorable direction towards T-DXd.
You said that this is impressive results, like seeing first line. We're getting above 40 months at the first interim analysis, so and it has a room to grow. It's fantastic to see, but then the dilemma starts here, right? The CLEOPATRA regimen have been a good regimen for a lot of people, and the beauty about the CLEOPATRA regimen, why a lot of people like it, and that's why I want to get your insight about it, is that there is an induction phase where chemotherapy, you do it for a finite numbers of cycles. It's not until further notice, and then you tend to stop after 6 months of therapy, and then just do a maintenance regimen, which is a lot gentler, where you do the dual HER2 blockade. And this is the time where you can introduce an endocrine therapy if somebody has what we call those triple positive type of breast cancer. The design of the Destiny Breast 09 was a little bit different. T-DXd was done until further notice. So two questions comes here. How do you think in academia versus community oncology, this induction plus maintenance versus just doing kind of an induction until further notice, how do you see that being like an obstacle, or actually it is not? Like, how do you feel it sits?
I think this is probably the most important question to be asked around that. The study is positive. I think there's no question about that. Then how do we integrate that into clinical practice? Are we going to give T-DXd for 3.5 or 4 years if the PFS even progresses further with more data? And then, that's one question. Then, of course, the second question is, what is T-DXd only arm is going to do?
Yes.
Because we know that the addition of pertuzumab is likely adding to toxicity. You're right. THP was so nice, the CLEOPATRA regimen, you tell the patient to bear with you for 6 or 8 cycles, and then after that, you're done. Well, from chemotherapy, and if they have a good response, you drop it and give them targeted therapy, hopefully with endocrine therapy, if they have ER expression. And then we know from the CLEOPATRA trial that many of those patients, years and years out, that tail was 20%, 15%, 18%, that go on for years. And that is really, impressive. If you look at the DESTINY-Breast09, the study allowed for the switching of T-DXd to trastuzumab for toxicity.
Okay.
But it was not a planned, switch after 6 or 8 cycles. Now the question is, do you give, people asking, do you give T-DXd and then switch to trastuzumab, pertuzumab? Well, I don't know. I mean, we know that even in the first 6 to 8 cycles, T-DXd is impressively more active than THP.
100%.
We know that. But is that going to carry on? Or do you really need to continue T-DXd for that duration of time? The second question is, if you look at the duration of treatment with T-DXd plus pertuzumab, it is really just over half of the time. So it's about 21 or 22 months, if I remember correctly. So what you're talking about is really a treatment that is both very, very deeply and impressively effective and also has considerable toxicity because it's being stopped because it's toxic, but it is so active that even stopping it, say a good proportion of the time, is still better than the alternative.
And that's what you guys mentioned, the depth of response that you see with T-DXd. But I want to go into that point a little bit deeper. We did see, like you said, it was a little bit more toxic. We see 12% ILD on that study, and there was grade 5 ILD reported. So there was death seen on that study, which is something, again, if I'm playing devil's advocate over here, you don't see that on the CLEOPATRA regimen, those death because of therapies. Is that a concern? Do you foresee that it's going to be done, especially in the community setting?
ILD has been one of those things that have been really interesting. People are scratching their heads with it because many people in the community felt that 10%, 11%, 12% could actually get less with, lungs that are less radiated or less pre-treated, patients who had really less. Now, remember, we're still dealing with metastatic patients for sure, but it has been stable. So we know ILD sits at 10 to 12%. And yes, there's been on-treatment deaths. But let's look at the alternative. A third of patients don't make it from front line to second line.
That's very important.
And so therefore, while I'm very cognizant of the toxicity and any on-treatment death is tragic, and I think it is horrible. But in the balance, there's a lot more patients who would have progressed, who would continue to respond. I don't think we answered in DESTINY-Breast09 the question of what to do long term. So is it that you give a certain number of cycles and you switch? Well, we don't have the evidence for that. Is it that maybe some people are going to say, which I suspect, is that people are going to say, well, listen, patient has had 11 cycles, their PET scan looks good, and they're getting tired of the treatment, so I'm going to call it toxicity and switch them. So, that might happen. Of course, people are always cognizant of the issue of the Patina trial and its results, and you don't have the ILD incidence there, and you have other toxicity, but you don't have that ILD incident. And so I think what we need, what we need is more maturity of the data. I think we need a deeper look at some of the secondary analysis of the trial, which I think are forthcoming both in ESMO and in San Antonio, hopefully. And I think we're also, hope that if there is approval, that we get the approval, and then what I always say, let doctors be doctors.
Let doctors be doctors. I agree, because I have a social media presence, and a lot of community.
I have not noticed that.
Yeah, I try to hide. A lot of community doctors were saying that, well, great. What I can do is I can give 8 or 9 cycles of TDXd, and then I will stop and do a maintenance regimen, and then I never lost that lines of therapy. So let's say you go on a maintenance and then patient progress, I can do another induction with TDXd. So what they speak a lot, and it kind of made a little bit of sense, because patient never developed toxicities from it, number one, if you stop it voluntarily. So it's not because of toxicity, and number two, it's not because of disease progression on the agent. So then the idea is you can always do induction, maintenance, re-induce, go back another maintenance, and you can keep doing that cycle and extend the life of TDXd instead of using it and then running into toxicities. Because at the end of the day, it is still having a payload. It still has a chemotherapy payload that the body has to deal with it. And eventually it gets tiring. So the idea, what do you think about those community oncologists that speaks that language, which makes sense? I mean, like when you look at it, it's not foreign language. You feel like you can sympathize with this theory.
So what I would say, this sounds interesting and plausible. I just don't know that we have the evidence to support that. So while I think that there is this, there's the art of medicine, and there's really the patient sitting in front of you, telling you 12 cycles out, 16 cycles out, that I'm tired. And also, let's face it, I mean, in DESTINY-Breast03, we know that we are giving TDXd for over 2 years if you follow the PFS, right? So it's not like we're that we're strangers to the idea of TDXd for a long time. And so we've all seen patients get a little tired. We've given them breaks. We've allowed them to feel well, to go on cruises and attend weddings and play with children or grandchildren. So these are all important. Now, I both agree with and also wonder about really that discussion, because I do think that without conclusive evidence, I cannot tell you that it is the best way forward, but I would say sit with your patient and look at them and decide what you want to do. Now, I would love to have a trial like that, where we basically do this and then say that when the patient progresses, you try to re-induce them and see if the next progression, when you really cannot give any one of those 2 regimens, would be maintained or not. 2, many ideas. One of them we're trying to do at Baylor and through the TBCRC, and there is a TBCRC study right now, a TBCRC 64 or the SAPPHO trial, led by Heather Parsons, where they're actually trying to look at really doing an induction regimen with all the different anti-HER2 regimens that we know work, and then monitoring the patient for a period of time. So I think that the community is going to answer, the scientific community is going to answer that question. And in the meanwhile, like you mentioned, just doctors are going to come up with whatever they think is best, and they're going to do it.
Yeah, it's an art, right? Oncology is still an art. No matter how much we try to change it, it's going to stay an art. Everything that happens between the doctor and their patient happens in that room, and if they agree on a plan, it gets executed. But you did mention the Patina, and I can't stop thinking about this Patina study. 44 months median PFS, 44 months. Wow. Can you tell us a little bit about the Patina study and how does it play into all this?
Patina, it came off of left field. It's not because we didn't know it existed. We did.
Yeah.
And it's not because, of course, it was, a very logical step. People had seen CLEOPATRA and, some of the studies. There was an alternative study that looked at dual anti-HER2 inhibition with lapatinib, trastuzumab, and endocrine therapy. There was the Pertain trial that we also did that showed that. And with Pertain, we basically showed that in the patients who did not need induction chemotherapy, you actually did, you got 22 months with trastuzumab, pertuzumab, and endocrine therapy. So it was reasonable to say, well, I want to do a deeper inhibition of that ER access and see if I could extend it further. There are two unique aspects of Patina. The reason I say it came off left field is because the results were so impressive.
Yes.
But I think we have to remember that Patina randomized after the induction chemo.
Yes.
Not before.
Yes.
And if you look at the first 6 to 8 cycles in that DB09 curve, you see that really about 15% of the patients more or less drop off or have a progression event in the first 6 to 8 cycles. Those did not contribute to the PFS of Patina. Okay, so that you got those folks who really responded.
Very important
now, I'm not,
insight.
Of course, it was better than the comparison. So it is for sure a positive study. But I think some people said, okay, well, I have the answer for you. I start with T-DXd for 6 to 8 cycles, and then I do the Patina regimen. And I'm like, that's a lot of drugs. But I think Patina is, the answer is that, of course, it will also require further, further follow-up. And I know they're taking another cut at the data and another look, a data cutoff. And so I think that we are going to see more results from it. I would say that if I see a patient who has a high burden of disease and I am worried about them, I'm probably going to follow the DB09 regimen just to get that deep response. Whether people would switch later on to your point, a TP plus endocrine therapy or TP endocrine therapy palbo, I cannot endorse it because it doesn't have evidence. But I would say that the art of medicine is extrapolating clinical trial results. But it is a very interesting study that I think we have to keep in perspective. And it makes our job harder, but it gives more options to 100%. The patients. And I would much rather have a hard job and more options for my patients than the other way around, where my job is easy, but unfortunately not with a lot of options.
No, that's amazing. Beautifully said. Beautifully said. I totally agree with you. I wanna get into the uncomfortable situation a little bit. Can we dare? I mean, we're talking 40 months plus median PFS. I mean, when I came into this field, I've never thought in my life I'm gonna see that in the metastatic setting. Can we dare and say we're the closest to a cure in the metastatic setting when it comes to HER2 positive?
Like you said, uncomfortable, as if it was comfortable before. It was very easy. Jason, I think you're spot on. So I think we need to think bold and act bold and dream big for our patients. But of course, not without losing touch with reality, right? Then I would say that the closest we are in breast cancer, and I might say in solid tumors even, to actually figuring out a way to have the patients live a normal life expectancy with metastatic breast cancer is with HER2 positive disease.
Wow.
And I think it's because we know at least the major driver. It's not the only driver, but we know the major driver of the disease. We know the second major driver, which is ER, in about half of them or slightly more. We know about some mechanisms of resistance like PI3 kinase, mutations and others. So we really have done a lot of work to understand that. I would never, I never trust cancer, so I'm not going to say that we are outsmarted, already outsmarted it, but I do think we are. And the SAPHO study that I referred to is really trying to really test that, be a first test for that concept. Let's throw everything we have for a specific period of time and then follow the patients and see if they relapse or not. I do think, though, that we will need our approach to be tailored. When we talk about multiple options for our patients, we're also talking about what is the best treatment for this patient. Not for a tumor characteristics only that has this mutational profile or this metastatic pattern, but for this individual sitting in front of me. And this is really the personalized medicine, the N of one. Really realizing the promise of precision oncology. When we are actually able to do that better is, I think, when we will be able to help more patients live with metastatic disease, a normal life expectancy, or dare we say cure. I think we're the closest in HER2-positive breast cancer, but not for us to rest on our laurels. There's still a lot more work to be done.
I love it. I love it. It gives a lot of hope. A lot of hope. And you know, like I can't stop but mention here that you were pivotal in looking at the crosstalk between HER2 positive and ER positivity, and you and our boss and big mentor, Dr. Kent Osborne. And when you block the HER2 blockade for long enough, there is a shift that goes to the estrogen receptor pathway, and it kind of takes the heavy load in giving an escape route for the cancer to grow. And then you block that one, and then it reflects back to this one. Mm-hmm. It doesn't seem like the Destiny Breast 09 gave a way to give an endocrine therapy with the TDXd. Do you think it's a missed opportunity, and do you think that's something that needs to be done in the future? Especially that you mentioned that the majority are triple positives, more than like 60%.
Yeah. So I think you mentioned a very important point. Of course, as you know, crosstalk between ER and HER2 is near and dear to my heart because of where I trained in the lab of Dr. Kent Osborne, and with that wonderful group that really helped put the idea of crosstalk not only into the biological context, but into the clinical context, and the idea of inhibiting HER2 and ER at the same time. Mm-hmm. And you're absolutely right that if you inhibit either one, actually, either axis, individually long enough, the tumor starts upregulating its dependence on the other side. So we have shown that if you actually inhibit HER2 alone, in both in preclinical models and in clinical patient samples, that you start upregulating ER and its downstream genes like BCL2 and PR. They start going up. So it's not only ER, it's functional ER. That's where really the rationale. And then many trials that we and others did kind of help put that in perspective. And I think it's a very well accepted concept in the field right now. So in DB09, really it was allowed to give endocrine therapy. What I was really surprised at is how few patients got it, under 10%, I think, got endocrine therapy together with TDXd and pertuzumab or whatever else the patients were getting. So it was just, we get, those numbers. And I think it is really, yes, it's a missed opportunity, I think, on all our collective part as treating physicians to give the patients the most effective treatment because we know that it works. Now, there are different practice patterns, and I have seen some people, some communities of physicians or individual physicians who are not really paying attention to that ER aspect for that. I would have loved it if it was required, because then we wouldn't be asking these questions. And we know that endocrine therapy adds very little, if any, toxicity to the treatments 100%. That we give.
And I've seen those patients coming up, training under you. I've seen those patients in your practice where you treat them with a HER2 regimen, and then you see after a while that the disease loses control, then you switch to an ER regimen, continuing the trastuzumab just to give them, and you get a restore of the disease. And sometimes you lose it, then you go to a pure HER2 regimen, and then you control again, and the switch back and forth. And then those patients, you can really prolong their survival drastically by doing the switch back and forth because of this crosstalk. So that's something I've seen, and it's under-tapped, definitely. And that's I'm grateful for the insights that you gave us about it. But I want to move on to something very interesting right now. So TDXd just came not long ago, right? Like it hasn't been a long time. I remember the first San Antonio, I was sitting there when they presented that San Antonio, everybody was talking about tucatinib, and right after I presented TDXd, and everybody fell in love with that drug. And it made at that time as third line, right?
Yes.
And then it made it up to second line, and now we're making up to first line. What do you tell the community oncologist that is telling us, what are you guys doing? You're killing our options. What am I gonna do after TDXd? What is the role of tucatinib now? What is the role of TDM1 now? What do I do with neratinib? Like, how is moving TDXd up front is doing to the other lines of therapies?
I mean, I've heard those arguments before, and although I do acknowledge some of those concerns, I don't honestly subscribe to the overall argument, for the simple reason that we have repeatedly, we as in the community of oncology physicians and researchers, that the more active agents are more active if you pull them up front. And if we know that about a third of patients in this day and age don't progress don't get second line after front line, why are we, who are we to say that we are going to keep a potent option as a second option?
I agree.
So while I 100% agree that toxicity is an issue, cost is an issue, so financial toxicity and medical toxicity, and I also do acknowledge that that many people report that disease that progresses on some of those potent agents like T-DXd is very hard to treat. They're hard to recapture a response to. I do acknowledge that. But I think that if a study like DESTINY-Breast09 shows us that it has an overall survival advantage, then we are helping patients live longer. And that's what we should do. Now, I think also we don't want to absolve ourselves of the responsibility of taking care of the patients the best way we could. Like you mentioned, what do I do with tucatinib? Well, anytime you have a new frontline, you basically don't know how anything is going to work after that frontline. And we saw that, for example, with T-DM1, right? It was, Emilia reported and got after, and it was done in the environment of TH, not THP. And then many people were like, well, is T-DM1 going to work after THP or not? And there was some real world data and some cohorts, one of them came from MD Anderson actually, that looked at T-DM1 after THP and said, well, it's maybe less active. So I think we're just going to have to sort it out. And we're going to have to figure out why patients become resistant to T-DXd and really design better treatments around it. And then, of course, we just had a long discussion about what is the best way to use T-DXd. And, do we use it, periodically? Do we use it continuously like it was done in the study? What's the art of medicine? What does the evidence say? And all those things. But I don't think that we don't move a drug earlier in the setting. I mean, T-DXd may move up front in the post-neoadjuvant
100%,
setting, right? I mean, we heard that DB11 is going to report, but there's also DB05, which is kind of going to be compared against like the Catherine regimen of T-DM1.
Yeah, and it's coming.
so if that is positive, are we going to say, what are we going to do? Of course, we have to use the best agent, the most potent agent up front. Of course, provided that their overall efficacy and safety profile is better than the alternatives. That is a must be. Then in particular instance, I don't think that we should keep those in the back pocket, because what would we do if the patient never made it to that line?
I agree. They say if you have your best player, you don't keep them on the bench until you lose the game and then you put them in. You want them there from the beginning. So I definitely echo what you said. I have a few more questions for you. If somebody comes to you today and asks you from the community, be like, okay, I'm sold. I gave T-DXd based on the amazing study. Now the patient is progressing. What do I do now? We don't have data. What Dr. Rimawi will do in second line after using T-DXd in first line?
So I think it would depend on how the patient is progressing. So one of the questions that were not yet answered by DB09, and it is a planned secondary analysis, is progression in the CNS. When every patient progressed in DESTINY-Breast09, they actually got a brain MRI. So we would know if those patients actually progressed in the CNS or not. So for example, if the patient had progressed in the CNS, then I would use a tucatinib-based regimen. The biggest question I have is pertuzumab after pertuzumab going to be active? So T-DXd pertuzumab, am I going to use a THP regimen or not? I think if I feel that if the patient progressed maybe without CNS, with CNS metastasis, tucatinib. Without CNS, I try THP.
Okay.
And then after that, I would try, a TDM1 based regimen, or I would try a TDM1 based regimen in place of THP if I didn't think the patient could take the chemotherapy. But I think the biggest question is CNS disease versus not, and in that instance, I'd use tucatinib.
And now I want to throw you another curveball, if I may. It's part of your DoD grant, so it's not foreign for you. You clearly showed that PIK3CA mutations, we underappreciate them in HER2-positive disease.
Yeah.
Those mutations intrinsically make those cancer resistant to our therapy or have poorer outcome to our therapies. Case in point, if somebody has PIK3CA mutation, their chance of pass CR is less in the early setting. It's really not tapped yet in the metastatic setting. Why do you think is that? And why do you not think it's a good idea to add a targeted agent to that pathway and improve our outcome even further?
So there are two ways to think about PIK3CA mutations or alterations, along the PI3K, AKT, mTOR pathway. One is their markers of resistance, and so if you do that, then the response to pure anti-HER2 would be curtailed significantly. And you're right, we have shown that with tumors treated with pure anti-HER2. Many of our colleagues showed it in tumors also treated with chemotherapy. They still respond, but less so. So it is a marker of resistance. So we need to think about it this way. And it is, in a sense, an untapped therapeutic potential, which we have not tapped into. Now, with DB09 or many of the ADCs, if the payload is so potent, it is really what I call an equalizer, right?
I like that.
It doesn't care if
PIK3CA,
PIK3CA is mutated or not, or there's an AKT mutation. If the payload makes it into the cell.
And they showed that in the DB06, right? In the subgroup analysis, that even if there is an ESR1 mutation, PIK3CA or BRCA mutation, it works regardless.
Not matter,
I like it, the great equalizer.
Yeah, and really in Destiny-Breast09, we actually stratified according to the PI3 kinase mutational status. And again, it was really no difference. So, but with a pure anti-HER2, or what I call a naked anti-HER2 regimen, I do think that targeting PI3 kinase may be a good strategy. PIK3CA, or PI3 kinase inhibitors, a problem with them is that because of toxicity, there's a limited potential for combining them. Now we're learning more and more about mutation-specific PI3 kinase inhibitors, and I'm excited about those because hopefully they'll have a lot less toxicity and would be more combinable. To really realize that therapeutic potential.
Fantastic. Lastly, I just want to talk about something you already touched on, is the chance of CNS relapse or metastasis in patients with HER2 positive. Because HER2 positive disease is an independent risk factor for CNS metastatic disease. And if you look at the natural history of HER2 positive breast cancer patient, up to 50% eventually will have involvement of their CNS. We have finally, thankfully, studies that looked at patients who have untreated lesions, and we finally have some activity of some agents. So three that come to mind: tucatinib based on the HER2 CLIMB, neratinib based on the NALA study, and T-DXd based on the Destiny-Breast12. How do you think those will play in those patients? You mentioned that if you use T-DXd first, you will likely do a tucatinib regimen. What would you do after? Like, would you do tucatinib by itself? Would you do it with capecitabine? Would you do it the HER2 CLIMB-02, tucatinib, TDM1? We're also getting from TBCRC, TDM1, neratinib. What would you do? And would you ever re-challenge TDXd down the line?
So that's about 6 questions in one.
I tend to do that.
I'll see what I could do with that. So it's a very fundamental question. And I think since if we're talking about analogies. In HER2 positive breast cancer, we said earlier that we're hopeful that it may be the first one we're able to kind of help patients get cured of with more knowledge. But I think if you want to say what is the final frontier or the most challenging frontier in that, it's CNS metastasis. Now, T-DXd, all those agents you mentioned are active. The difference is, I think T-DXd is probably active when you have active brain mets or active leptomeningeal disease. The question is it going to be active if they're not clinically detectable? Meaning, and this is what DB09 is going to tell us, are we going to see patients progress with more incidence of either symptomatic or occult CNS metastasis, meaning that when there isn't clinically detectable CNS disease, that TDXd doesn't work against it, and so therefore the patients could progress in it. Think of what we saw in terms of progression, CNS progression in Catherine.
Yes. Oh,
Yeah.
yes. Shocking.
Yes. And so, or is it going to be that it really has some activity and we're going to see less?
Yes.
Because remember, you're moving it earlier, so you're getting it less contact with CNS disease. Now, beyond that, but to answer your question, frontline patient has brain mets or not, I think TDXd is going to be active with pertuzumab, knowing what we know today. Second line, when I say a tucatinib-based regimen, I'm just trying to leave it to the physician to do TDM1 tucatinib versus tucatinib cape trastuzumab. I and many others have found that it is better tolerated to give tucatinib and cape with trastuzumab. And I really like the idea that also cape gets into the blood-brain barrier. So you kind of have two agents. But I wouldn't fault anyone for doing TDM1 tucatinib. What I would do is I would maintain, neratinib for, as another option. I think it has really good data. It is an underutilized agent that is very active, that we know from work from our group, that really from Rachel Schiff and Jamuna Viraragavan, that really the mutational pattern is different between tucatinib resistance and neratinib resistance, and neratinib could be helpful in some tucatinib resistant cells. So that works well. And we were all worried about neratinib and diarrhea. I think in breast oncology, we're now experts in helping patients manage diarrhea. So I think it should be an active agent. And you could also give it with CAPE if you haven't given it, or you could give it with TDM1 based on the TBCRC22 study if you have given it.
And I have to say it, when I trained under you, you were the one who said that people who complain about the diarrhea of neratinib are the people who never give it, who never gave it. Because you're right, once you start giving it, it's not that bad. It happened early, it's self-limited, it goes away. But that's changed my idea to that drug, and I started using it more after training with you. So that was amazing how you said it. But this is amazing insight. I really want to thank you. I mean, this is fantastic. I really want to thank you for joining us today, and I hope we're gonna do a lot more of those together. Thank you so much for your insight.
Thank you, Jason. This was fun.